Uh, Good afternoon, and thank you, Sudipta, for putting me here. And it's an excellent session. I see fairly good attendance here. Uh, well, in the next few minutes, myself and Dr. Chaudhary is going to talk about decoding multifocals for optimal, patient satisfaction. This is something important: optimum patient satisfaction. And to go for the basics, actually currently cataract surgery with a monofocal IOL implantation is one of the most commonly performed surgical procedure in the world. But with the expanded use of screen devices, standard monofocal IOLs may no longer, serve the visual demands of population, which is increasingly interested in activities that would require good quality intermediate as well as near vision. So we have the choices of multifocal and EDOF lenses as well. Now, as the ASARS Cataract Clinical Committee states that not every currently available IOL is suitable for every patient. So we need to kind of understand the need of the patient, counsel them properly, and understand the visual needs of these patients, and then select the IOL. So this is something, a good guideline that has come up last year. Well, as for the IOL selections, we have a lot of choices. We need to look at the material, the platform, the optical design, and of course, as has been discussed for torics, IOL power calculation formulas need to be correctly chosen, like the Barrett's and Kane and whatever modifications we need to use. But let us remember that the right kind of model formula goes a long way for patients, for optimum outcome and patient satisfactions. I'll just take a few points, which are really important. The axial length, it should be, it's recommended that 22 to 27 are good to choose these kind of patients. And similarly, IOL powers 10 to 27 diopters. But yes, away from this range can also be done, but with little precaution. We need to take steps. We all know that longer axial length eyes are more prone to have retinal comorbidities, and the shorter eyes may have IOL tilt and also difficult to calculate the IOL power. So there are a lot of other cons associated with it. As for the keratometry, astigmatism correction, as we have just discussed about monofocals or as a whole torics, the higher the astigmatism correction we aim, the more, difficult it is if there is a small degree of rotation. So we need to be careful that in multifocals and as the topic suggests, optimum satisfaction would be brought about in, if we choose something, not a very high astigmatism correction, it should be a moderate correction. And of course, the AC depth again matters because the add power would also change. Well, as for the pupil size, the optimum range of pupil size that is recommended is, more than 2.8 mm in photopic condition and less than 6 in scotopic. There are a lot of contraindications. Some are relative, some are, absolute. So one thing we need to mention, as always, in the first talk, it was mentioned very rightly that dry eye disease needs to be treated first. And of course, keratoconus being an absolute contraindication, whereas, the previous history of any refractive surgery is just a relative contraindication. We need to look at the higher order aberration, the amount of it. If the RMS is less than 0.4 microns, maybe we can take up these cases. Well, I'll just end with a small video. It's a very interesting case. This is about a patient whom I had operated 10 years back with Restore implanted in both eyes. In 22, he had come for a checkup, everything was fine. But last year he came with this feature. The lens was, actually there was a spontaneous rupture of the posterior capsule 10 years later after surgery. So I thought this is something really different I have never encountered. I look at the literature, there are publications. And I was really surprised to see there are publications that spontaneous rupture can happen even after 10 years, or it has been reported even after 17 years. So in this case, if we talk about optimum outcomes, it's really a tricky situation to decide. Now, I discussed with the patient that we'll do vitrectomy and take out this lens and replace it with, because a multifocal lens is not available with a multi-piece design. So I said we'll put in a monofocal lens multi-piece if the anterior capsule, which looked clinically very, adequate. But the patient was demanding, but he was really ready to take a lot of risks. He said, please try with the same lens. If I explained that this particular model is not made for sulcus fit, but he said, okay, if we have, as you said, a lot of complications may happen, we are ready. If this happens, we are ready for a second surgery. So he said, okay, that will be a third surgery, no problem. So we did a vitrectomy, and as you can see, a sulcus fit was done, and optic capture was done. For lack of time, I'll just show you that, it was done properly aligned, but then after an optic capture, it was pretty stable. And almost a year now, he had come for, checkup, and he's still maintaining 6, 9, and 6. The other eye is 6, 6, and 6, unaided. But yes, we are still apprehend there may be complications later, but he is very happy. Right. Thank you. So optimum outcome could be different in tricky situations. Each patient has to be, customized for their demand and need. Thank you.
Thank you.